Operation for a mastectomy involves removing the breast, and in most cases giving the woman the option to have immediate reconstruction. It's an operation that we do now is much different than it used to be. Years ago they did something called a radical mastectomy that involved removing the skin of the breast as well as the nipple and the brown tissue around it called the areola, and then it would take the muscle underneath the breast, the muscle called the pectoralis major, and a large number of lymph nodes underneath the armpit along a vein that carries the blood back from the arm to the heart. What we discovered years ago, in fact it was discovered in the 70s, that aggressive operation is almost never done. I've never had to do that operation. A radical mastectomy is almost of a historical interest only. In the 80s they started doing something called a modified radical mastectomy. It's less aggressive. It involves removing the same amount of skin and breast tissue but fewer lymph nodes and leaving the muscle intact. Removing the muscle really was found to not make any difference at all, and there's a lot of there are a lot of side effects and morbidity related to removing the muscle, and there's much more lymphedema, the terrible swelling that can happen in the arm and trouble using the arm, the more aggressive the operation is. So in the 70s and 80s they did a modified radical mastectomy, and that still has to be done sometimes now if the woman has a significant amount of tumor in her armpit. Then she would need a modified radical mastectomy. But typically today, we don't do modified radical mastectomies. In most cases, we're able to find breast cancer before it's spread to the lymph nodes. And what we do is we remove a portion of the skin, as well as the breast tissue. We leave the muscle behind. And we do something called a sentinel node biopsy, where we just take out a few lymph nodes, the lymph nodes that are most likely to carry the cancer. Because actually removing lymph nodes doesn't cure cancer. It just removes lymph nodes, particularly if they're normal. What we want to find out is there tumor in the lymph nodes, and if it is, then we need to be more aggressive, and those are the women that will need chemotherapy. Taking out a lot of lymph nodes has not really ever been shown to cure breast cancer. It just means that the cancer is more aggressive, and it does significantly increase the risk of problems to the arm. Most women who have mastectomies today do have immediate reconstruction. It is not by any means a requirement. A lot of women choose not to have immediate reconstruction. Immediate reconstruction involves working with a plastic and reconstructive surgeon to rebuild the breast. Sometimes they'll take tissue from the back or the tummy, or sometimes they'll put an implant underneath that muscle that we didn't take, and they'll rebuild the breast that way. And there's several different options, and that's something that we would want the person to talk about with the plastic surgeon prior to surgery. The operation for mastectomy usually takes about an hour. With the sentinel node, it adds another 30 minutes, so it's about an hour-and-a-half operation. Some women go home the same day, but most spend the night in the hospital. There is a plastic tube that drains some fluid. We have to teach the patient and the family how to take care of this. We want to make sure pain's under control, the patient's able to take fluids and eat before they go home. And so most people spend the night. Occasionally a woman will spend 2 nights, but generally they spend 1 night after a mastectomy. The biggest advantage of having immediate reconstruction is that you can have one less operation. It does take longer. If my operation takes an hour-and-a-half, it may take several hours longer. But it is much easier to recover from 1 longer operation than 2 moderate operations, and it's much easier to recover. The cure rate is absolutely the same, and we find that women do better physically, emotionally, and psychologically from having immediate reconstruction. Candidates for immediate reconstruction, most women are candidates as long as they're in reasonable health, and they're not going to need radiation. If a woman's going to need radiation, most plastic surgeons will not want to do immediate reconstruction, because if we radiate the reconstructed area of the breast, a lot of times that area is damaged, and if it damages the reconstruction, that's a problem. It might burn a bridge that we could have used for a delayed reconstruction later. If they don't have immediate reconstruction, it's much simpler, and the recovery is a lot shorter. Most people have the tube taken out somewhere from 7 to 14 days after surgery. I've seen it come out as soon as 5 days, but sometimes it can take longer than 14 days. Once the tube is out, generally women get back to their regular activities pretty quickly. If the woman has immediate reconstruction, the recovery can be much longer. It can be many weeks longer than that, because there are a lot more issues involved. There are more tubes involved. There's more tissue involved. And in addition, if the woman has a tissue expander, which we often refer to as a balloon that's put underneath the muscle, if that has to be expanded, it takes several weeks to get that where we need it to be, and then that is exchanged in a second procedure later. The biggest advantage of having immediate reconstruction is that you can have 1 less operation. It does take longer. If my operation takes an hour and a half, it may take several hours longer. But it is much easier to recover from one longer operation than two moderate operations, and it's much easier to recover. The cure rate is absolutely the same, and we find that women do better physically, emotionally, and psychologically from having immediate reconstruction.